Greetings, everybody, and welcome. Today, we're going to be talking about the biofilm associated impact on cesarean section outcomes. To let everybody know, my name is Christopher Basile. I'm an OBGYN physician out of Obstetrics and Gynecology of Atlanta as a private practice, and I am currently the vice chairman and soon to be chairman of the Department of Obstetrics and Gynecology at Northside Hospital here in Atlanta, Georgia, which is well known as the busiest obstetrical hospital in the United States. In 2020, we did a little over 15,000 deliveries, currently known as the busiest obstetrical hospital, and I'm a private practitioner in one of the busiest practices at Northside Hospital. Today's program is brought to you by, it's provided by the North American Center for Continuing Medical Education, an LLC company that's also an HMP global company. And this is supported by an educational grant from Next Science. Today's objectives, we have several learning objectives, and those include examining the incidence of surgical site infections following C-sections or cesarean sections, also recognizing the physical and emotional burdens that are on the patient and the financial burdens that occur to the healthcare system regarding the surgical site infections from C-sections. And another objective is to investigate the importance of timely treatment of biofilm in the immediate and intraoperative period, and also to examine the approaches of evaluating new surgical antibiofilm technology. Of note, biofilm seems to be a huge thing in the materials management world. It is known to certain physicians, especially ones that deal with hardware and implants, such as orthopedic surgeons. I think it's less knowledgeable to the OBGYN world and to other physicians that aren't dealing, that we're dealing with bacteria, but don't understand the impact of biofilm. So this is a good way to educate the population on the medical population on different aspects of antimicrobial management. So cesarean sections, 1 in every 3 C-sections is resulting in there's 1 in every 3 deliveries is resulting in a C-section. Currently, there's about 3.8 million births per year, and that breaks down to about 1.2 million C-section births a year. And 480,000 of those are just scheduled C-sections, where people coming in getting their repeat or their primaries due to some reason, such as abnormal placentation, abnormal fetal lie. These are all like abnormal fetal size in relation to female pelvis. So these are all reasons why we see scheduled cesarean sections that occur as well. So these are C-section rates across the board of the United States. And as you can see, the top 10 states fall into, the majority of them fall into the southeastern region. This also correlates with one of the biggest risk factors for cesarean section, which is obesity. Of note that in the southeast region, the majority of these states fall into the top 10 states for obesity as well. So when we look at these risk factors and the C-section rate risk factors, the Southeast is a high number here. In Atlanta, Georgia, we're right in the heart of that. So studies coming out of Barnes and Jewish Hospital out of St. Louis, Missouri at Washington University, which is a hospital that predominantly has 4,000 deliveries a year. They evaluated 1,605 patients, and they used their data on collection, essentially using several variables, but mainly on antibiotic use during hospitalization, during readmission to the hospital, or during an ER visit. And they compared patient-related variables, demographics, comorbidities. They compared obstetric-related variables, looking at the parity, the mode of delivery, the membrane details, like the length of the time of rupture of membranes, time to the time of the rupture of membranes, and if they had ruptured membranes, the different ways that they had induction methods, the number of vaginal exams. This was all obstetric-related variables. Operation-related variables, they compared the ASA scores, the urgency of the operation, stats, cesarean section versus emergent versus urgent versus just routine, whether or not there was uterine exteriorization, what was the closure method used, what was the EBL, and what antibiotic prophylaxis was used. And they basically used the ICD-9 diagnosis code for surgical site infections or wound complications. They also compared that using categorical variables, using a chi-squared analysis or Fisher exact test. And they used continuous variables that were compared during the student T or the Mann-Whitney test, Mann-Whitney U test. And what they found was 81 patients out of these 1,605 developed a surgical site infection, which narrowed down to about 5% of the population undergoing C-sections. And they found that the independent risk factors for surgical site infection included the development of a subcutaneous hematoma post-procedure, the operation being performed by the university teaching service, a high BMI, and whether or not, which just caught me off a little off guard, was use of staples for skin closure. And that was marginally increased for the risk of surgical site infections. So essentially, that was a study design, and they excluded the patients that had an active infection or endomyometritis, choreo. They included basically the C-section patients within a 2-year time frame. And then this is just basically, as I said, they had a 5% infection rate. Now, let's evaluate the impact of an infection, because the impact of the infection affects not only the patient undergoing the infection, it affects the healthcare system, it affects everybody involved. Let's just go along with the mom. You see the impact of problems. You have bonding time with baby that gets affected. They're hurt, they're not feeling well, they maybe have fever, chills, general malaise as the immune reaction is trying to fight this off. It impacts their breastfeeding. Breastfeeding alone takes a toll on the mother. Now they're not feeling well as it is. And again, the immune system is doing its work, as the process of the immune system is going through and fighting infection. What's it doing? It's draining the resources from the mom. In this postpartum time frame, they are already limited resources. They're lacking sleep. They're lacking adequate nutrition. They're not doing exercise or stress management. It's a high physical and mental stress level. Not only do they have the fatigue and the exhaustion, but despite modern medicine, there's only one person that can breastfeed, and that's the mom. And let's forget about just the other factors, the social factors. So if this is their second baby, third baby, you're going to have jealousy factors from siblings that are involved. You're going to have just maintenance of household, and you got the financial stresses that can come along with it, and just across the board, just difficulties in childcare, the healing time that's having to go on. It is a very stressful time, and let alone there's the loss of that bonding time that happens because they're having to deal with it, no matter which way it's managed, whether it be on antibiotics, whether it has to be wound dressings, whether it has to be a wound vac. The management of a surgical site infection can be difficult. Antibiotics can take a toll on the mom, especially with some of these that are breastfeeding. They're limited, so a lot of times you're doing some of the cephalosporins that are 4 times the daily dosing, 3 to 4 times the daily dosing. There just can be a pretty significant impact on multiple levels. And then that affects the family as well. Everybody always say when mom is struggling, the family's struggling. And so it hits hard, and it doesn't just hit the mom by itself, it hits the entire nucleus of the family. Now we move to the healthcare system, and then, if you just look at a C-section surgical site infection, that can be anywhere from 3,400 to 17,700. And that's a statistic coming out of infection control from the Hospital of Epidemiology. And that, if you just assuming that 5% infection rate, that can cost the healthcare system up to $1 billion a year. You got increased healthcare costs, increased physician visits due to follow-up. So all of these, there is an impact of the infection that can hit not only on the family nucleus, on the mother, but it also hits the healthcare system. So let's look at, traditional strategies on what we do to help prevent infections. And the literature is going on pretty significantly about this, and it's ever changing. I'm going to preface a little bit about this. Being on the administrative side at Northside, I do know one of JCAHO's biggest mandates right now is surgical site infection. And as I'm sure that everybody who's in a hospital setting and dealing with a lot of the bundles that are coming out, they call these the order bundles that are coming out for surgical site infections, you're going to see a lot of this. JCAHO is having this big push to make sure that we reduce surgical site infections. On the insurance side, there's a movement headed toward episode of care, and this is going to be huge because they're not going to continue to pay for every visit coming in for surgical site infection follow-up. You're just going to get the episode of care. So it's become a huge movement right now to address surgical site infections across the board. So current strategies that we use, preoperatively, we use systemic antibiotics, classic being a cephalosporin. Prior to surgery, when I was in residency, this was at the time of cord clamp, then we moved to prior to surgery. Doing surgical site prep, that can be done by both the patient and the hospital. Some hospitals will have the patient do a chlorhexidine wipe or a wash the night before. And then we do the ChloraPrep or DuraPrep at the time of surgery. Removal of the hair from the surgical site. Initially, we were shaving them in the OR or trimming them in the OR. Now it's being done before you get to the ORs to make sure that there's no hair on the field. You got environmental controls, the temperature of the ORs, and they have all the standards with sterilization of the instruments that comes in proper sterilization of the instruments. There's also simple things that we do like scrubbing, which, I laugh at that a little bit because at one point I did give a talk on sepsis, and we were operating for a little less than 100 years before people were like, oh, maybe we try washing our hands and that'll make a difference. So it's an interesting, but hand hygiene also plays a role into the surgeons. Post-operatively, once again, we can use systemic antibiotics if there is some sites of infection. We got things like silver dressings that we use, or silver-coated dressing. Ethicon makes a bunch of antimicrobial sutures. Doing moisture management, so women with panuses, a lot of times we'll put something to try to maintain that moisture management and maintain the humidity levels. Using vac therapy, and these are things like the Provino, the Provino wound vac or the Pico wound vac. Patient education. So patient education, that comes huge. Nutrition is so key to a fundamentally well-working immune system. And nutrition is very key across the board. And I always say that the more I do medicine, the more I realize how much nutrition plays a role into this. And let's face it, one of the biggest keys to maintaining a healthy immune system, and this is where it comes to patient education, is sleep, stress, maintenance, and nutrition. What kind of lacks a lot during that first 6-week period? Sleep, stress maintenance, and nutrition. So trying to maintain patient education is helpful. And then, of course, hand hygiene. Hand hygiene is critical, and we talked about that recently. So in order to start the process and understand a little bit of how we're going to attack this and kind of anything new in the armamentarium we can use for treating surgical site infections, we need to go through the phases of wound healing once again. And wound healing can be defined basically as the physiology by which the body replaces and restores function to damaged tissue. So this initially starts with the initial insult. So the cut, the scar, anything. The first role of the body is to achieve hemostasis. So hemostasis occurs, and that occurs through a combination of vasoconstriction, platelet aggregation, and then the formation of a blood clot. And then you get, and then this process, it occurs immediately after the injury. You reduce the blood to the wound. That's where the vasoconstriction comes in. And then those platelets are able to aggregate and help form that clot. And it leads, basically the clotting cascade comes in and puts it on there. So within the first 4 hours, platelets are maintaining that. And then after 4 hours, that clotting cascade has been playing the role and has now formed a nice fibrin matrix to stabilize that clot. Next, you kick into the inflammatory response or the inflammation. And that's basically the body's natural response to injury, and typically lasts about 72 hours. You get swelling, capillary leak, vasodilation, intracellular edema. Or basically what happens is within those first 72 hours, you get the influx of the pro-inflammatory cytokines that increases the capillary permeability. You get vasodilation and you get intracellular edema. And then it's at this stage that you start seeing those characteristic signs of inflammation that can happen. You get the erythema, you get the heat, the edema, the pain, and you get functional disturbance of the tissue matrix. Additionally, this is where you start seeing some of the migration of the neutrophils, and you basically, they come to the site of the injury and they start digesting the bacteria. They start breaking down the debris and the necrotic tissue that's there. Next, you move into, or the next stage you see is proliferation. And proliferation, this is where you get the rebuilding process. And you basically get the formation of granulation tissue. You start getting reepithelialization within the wound. It's characterized by the generation of a new vascular supply, or otherwise known as angiogenesis, and the formation of a new cellular structure. And this is usually done through the fibroblasts. It results in the developing wound structure and increasing the tensile strength within the wound. Just of note, the maximum granulation occurs right around 5 to 7 days, and it's usually associated with that angiogenesis. And facilitating the angiogenesis is basically facilitating the process of cellular regeneration and wound healing. This entire matrix is consistently happening, and as I'm going to mention in a brief minute, a lot of this tends to interlap over it. The color, the condition of the granulation tissue, it's often an indicator of how that wound is healing. Dark granulation tissue is very concerning. And it can be indicative of poor perfusion or ischemia or infection that can happen. And then the last stage you see is remodeling. And this is where you start seeing the final phases of wound healing. You get the extracellular matrix deposition, you get the tissue remodeling, the wound contraction. Both remodeling and proliferation tend to overlap on each other. And it continues anywhere from months to a year later for the wound healing. There's an article that came out years ago that talked about, that moment, that aha moment, generally after abdominal surgery, and especially it was in reference to C-sections, where people have that, I feel great, I'm finally back to normal, is about 6 months post C-section. During this remodeling process, you see the synthesis of collagen, you see reabsorption of the original collagen, and then you replace it with another stronger type. And then these collagen fibers get reoriented, and they provide a stronger tensile strength under the influence of the local stresses that are on the wound. So it's a dynamic response when you look at healing and the healing process. And it's not a linear response. It's often, they can progress both forwards, they can progress backwards, they have different phases, depending on what the intrinsic and extrinsic factors are at work with the patient. But across the board, these are the 4 phases. And like I said, a lot of these tend to overlap together. So we rely a lot on antibiotics and antimicrobials, but how do they work? Antibiotics, they work mainly on the cell wall distribution, on the cell wall disruption. They interfere with reproduction and they block protein production. So we're trying to basically get around that cocoon or that shell around the antibiotic and getting in and preventing its replication from happening. Just basically creating just a giant stopper or giant firewall, if you will. The antimicrobials, they basically deal with protein damage as well and the cellular disruption, but they also add oxidative damage in there and DNA disruption. So essentially, the big thing with the antimicrobials, when you start hitting those, you basically start attacking the proteins of the microbe, and that causes it causes a failure for basically the essential functions of the cell and how it works. When you start dealing with cell wall disruption, they start losing critical nutrients. There's a great electron micrograph, and you can Google it, of how the immune system actually starts disrupting, and it puts basically protease polymers into the cell wall of bacteria, and you start seeing that essentially the cell the bacteria starts spilling out its contents. It's basically, you create a big hole in the cell wall, and it has, the easiest way I say it is, it's like if you're flying in an airplane and one of the windows open or gets ripped off, or the door opens up, it's like a giant vacuum or suction, and it causes the protein contents to just spill out. You get oxidative damage, and you increase the oxygen level, and that basically damages the internal systems of the microbe. And then, of course, interfering with the genetics and the DNA of the microbe. So these are the way the antibiotics work. These are the way antimicrobials work. And we use them as a benefit. And we rely on them pretty heavily. Now, this is where I'm going to introduce the concept of the biofilm. And biofilm is the continued source of infection. Biofilm is defined as the community of pathogens that is enveloped within a complex structure of entangled polymers strengthened by metallic bonds. All right. You basically have this community of pathogens. You got the polymers that are together, and the microbes tend to secrete this protective matrix called the EPS, or otherwise known as the extracellular polymeric substance. We'll be talking a lot about that today. That's made from these polymers. It contains proteins, it's got glycolipids, it's got polysaccharides, and then it's held together through metallic bonds. And these metallic ion bonds help form this resilient barrier. So in Atlanta, currently, we have a lot of construction. And the best way I can say this is, if y'all ever see like any concrete post or any roadway being laid, what do you get? You get the metallic rebars that are laid down, and then the concrete poured on top. So that's a great kind of analogy that I can look at with this. You got the metallic bond that is being formed, and then this helps form together with the entangled polymers of the cells, help create this beautiful bond and the strength. So think about a concrete column. I mean, that's strong as can be. That's how this biofilm works. And one big analogy I like to use when I'm talking about biofilm is, just think about a castle structure back in the Renaissance eras and medieval times. So you had the castle, the walls protected the castle, and there was an entire community that occurred within the castle. And it was a protective community, and you'd have to try to break through to get into there. So just to show you, this is a great a Staph aureus on a Foley catheter. This is a great electron micrograph. And you can see that Staph aureus here is forming its little matrix all across here. So this is part of the biofilm that it's creating in this picture. So the big thing that we need to understand is that antibiotics and antimicrobials have little to no impact on that biofilm structure. So this is a great 3D rendition of the biofilm. And you can see how here within the biofilm, you can see the bacteria is protected. And here are the metallic bonds that are keeping everything together. And the best thing that I can say is it's almost like an abscess. So think about the biofilm. When we look at abscesses, right, you can't hit an abscess with an antibiotic. You can't hit an abscess with an antimicrobial by itself. You have to actually break the rind of the abscess, get into that and drain it. And that's how you attack an abscess. So, I mean, basically with the bacteria forming this protective structure with the EPS, you know, some of this, there's examples in nature that you see. There's things like moss in healthcare. One of the biggest things that you see of the EPS is the plaque on teeth, where you got this entire network and you got this community of pathogens that are in there, and that plaque is performing that rind. In nature, you got moss that coats, you know, a humid area, and there's a lot of bacteria within there. Biofilm itself, it's not understood well a lot in surgical care. It's very well understood in the materials management, but as surgeons, we generally aren't as in tune with it unless we do a lot of hardware work. So a lot of like orthopedists will be aware to it. But the majority of us other surgeons that don't really deal a lot with implants, not as knowledgeable about this. So this is why I like to introduce the concept of biofilm. Majority of the resistance of the bacteria that we see with antibiotic resistance, it comes from the biofilm population, and it is conveyed by that EPS. It creates that physical barrier, and it obstructs the penetration of those antimicrobials, and it makes it a lot tougher to treat. To eliminate the biofilm, you basically have to have treatments that focus on comprising the structural integrity of the EPS. And we got to try to destroy that, be able to have effective antimicrobial treatments that are going to attack this film region, not just the bacteria. If you can't get to the bacteria, all the benefits of those antimicrobials and antibiotics don't do anything. So this becomes the challenge and when we're dealing with biofilm. And you understand, biofilm, it's not this, it doesn't take this, it starts forming in 5 minutes. And then when it starts forming, it can generate pretty quickly. So you start with just the free floating, the planktonic fibers. They start, they basically, they create this conditioning film, and that film, it has proteins, it has sugars, it has blood products, and you can basically see it like existing and being newly formed on any virgin surface, and it starts within milliseconds. Then you get this reversible, then an irreversible adhesion and coadhesion of the first bacteria colonizers to the conditioned surface, and that takes about seconds to minutes for this to form. Then they start multiplying, and that multiplication of the microbes form a very distinct microbial aggregates, all right? And these are called the microcolonies. So you start seeing these microcolonies. This happens within hours to days. And then you start getting maturation of that biofilm and more production of the EPS, or the extracellular polymeric substance. And this starts the formation of water channels within hours to days. And then you get what we call microbial hemostasis. So this is where it's finally found its nice, good network. It's got its community built. The castle is built. And then now you basically, they detach and you go on and you form more and they move on to the next place. So it's now sending out its team to start a new world, a new castle, a new community to go on from. So again, as I said, within 5 minutes it develops, and this is a great, basically this is again a similar micrograph of Staph aureus on a Foley catheter. So when conditions are favorable, such as having the right temperature and the nutrients available, some bacteria like E. coli, they can actually divide every 20 minutes. And so that means, in the ideal scenario, one E. coli bacteria can go from 1 to 2,097,152 bacteria, literally in 7 hours. At one point in med school, I remember us given kind of a similar project where we were given the project to basically try to determine, in the ideal scenario, if left undisturbed, what one bacteria, how long it would take to go from one bacteria to cover the entire world. And through working that out, we came up with, it was about a day and a half. So in the ideal scenario, left undisturbed, it will take a day and a half for a bacteria to go from one to covering the entire world. So, it's important to understand the concept of what we're dealing with. And this is critical in surgical site infections. One thing you got to understand about biofilms is in the in vivo model, successful biofilms, they're able to hijack and commandeer the host responses, such as the inflammatory response, such as using a lot of the hosts, just building products and building blocks for their own advantage. So this is a great electron micrograph comparing using basically Staph aureus. And in this graph, it's actually showing that Staph aureus is using the host fibrin or fibrinogen. Basically, Staph aureus secretes staph coagulase or coagulase, and that polymerizes the fibrinogen into fibrin fibers, and it starts to, over time, weave a very nice web around the biofilm. So you can see within 5 minutes, all the way to 15 minutes, you're already starting to see this web. And then that carries to within 45 minutes. Look at this matrix, at how quickly that has developed. It gives a stronger attachment to the wound. It gives a great physical protection from the environment. This makes the biofilm more effective. It makes it harder for the host to clear, especially when it's using the host products. And basically subverting a lot of the host responses is actually clinically very important in biofilm-based diseases, and adds a lot to just the array of defense mechanisms that these bacteria possess. So you can see, I mean, going from 5 minutes to within 24 hours, the sheer nature of how this matrix has developed. And I mean, we go from a simple bacteria all the way to this almost like nebula of the biodome that is here within 24 hours. So let's look a little bit about how this works. And so just to bring it home, we're going to evaluate a study and that mainly focused on obese women. It was basically looking at the skin microbiota in obese women and looking at the risk factor for surgical site infections after C-section. This was published in Nature magazine. It was a prospective observational collaborative study from the Buckeye State, Ohio State University, and various affiliated hospitals and research institutes. They did scheduled C-sections at term. And they compared non-obese to obese patients. And with this, they basically did studies of culture gathering both before prep, after prep, post-operative in the incisional area, and they did biofilm counts on that. They did surgical antiseptic. They did basically prep the patient. They did a culture at the phanestoel site, and they evaluated the biofilm there. And what they found, and this is going to be highlighted a little better in a subsequent slide, but that in non-obese patients, the bacterial load was not impacted so much by the surgical site, by surgical antisepsis, such as the chlorhexidine or the Duraprep or ChlorPrep. However, in obese patients, it was a significant reduction by using an antiseptic agent. However, following the wound closure, they basically evaluated and cultured the edges of the phanestoel skin incision, and they found that they had a very high bacterial load compared to the skin area immediately after scrubbing. So this was after the surgery was done. Everything's said and done, still sterile field. They did cultures, and they found that there were still high bacterial counts, and that level of added bacteria wasn't any different for the obese versus the non-obese population. And then they subsequently did studies or subsequently figured out that within 14 days after C-section, 15% of them actually developed a surgical site infection, and this was higher for the obese population. So this brings it home. Essentially, with this study, I know this is a busy slide, but just to understand a little bit, they essentially, when they did, and going back to this slide, it tells you the different areas. Time one was their control group. This was before they started, all right? And what they did to minimize the variability, the skin prep and the collection of swabs was performed by one single investigator, so that it was always minimizing the chance of any variability between that collection. So this was before they did any antiseptic, before ChlorPrep, before Duraprep, or whatever the hospital uses. And they basically did swabs. The control group was behind the ear, retroauricular crease. They did it on the forearm as well. and they did it in the mid-abdomen, basically the phanestoid site, and they did it in the vagina as well. In their study, they used ChloraPrep. They also did a culture of the ChloraPrep applicator. This is at time 1, and of the surgeon's glove. At time 2, and this was after the skin prep, but before the skin incision was made, they obtained the swabs basically from the abdomen, from the mid-abdomen and the phanestoid sites. And they also did it at the ChloraPrep applicator after the skin prep. At time 3, which isn't in here, that was done intraoperatively after the skin incision and prior to the opening of the peritoneal cavity. They excised a small sample of skin from the lower edge of the incision, and they collected samples from the lower uterine segment and the surgeon's glove after delivery of the neonate. So this was time 3, sorry. This was time 3. And then time 4 was at the end of the procedure, post-operatively, once the skin was closed, prior to the application of the sterile dressing, and it involved doing the collection of the swab directly from the surface of the incision. All right. What they found, and this blew me away, before the prep, the bacterial loads before the prep and after the prep, there was a significant, so before the prep and after prep, and no difference in the non-obese group, but there was a significant difference in the phanestoid site in the bacterial load in the obese population after doing the prep. However, after the surgery was completed, and again, this kind of blew me away, the bacterial load went right back up, and you had the bacterial load on both ends. Now, sure, part of this is we know that you can introduce bacteria, especially in that primary, the person who's getting the primary C-section for failure to progress or arrested descent. They've been checked. There's basically vaginal bacteria that's gotten up toward into the uterine cavity, and then that gets through to the skin incision as you pull the baby out. So this is obviously through multiple like vaginal exams that can happen. But across the board, you know, we rely on this vaginal prep, and we rely on the skin prep, on the abdominal prep to do the phanestoid skin incision. And this shows, like, at the end of it, you know, I think I walk away thinking, okay, my antibiotics did the trick, and, you know, my prep did the trick, but here we go. It's basically showing that it didn't matter if they were obese or not. In here, there was still a higher level of bacteria that was there at the end of the procedure. And then when they kind of looked at it, so basically, what we look at, log values are the way that the FDA kind of looks at, or the way the microbiologists essentially say we are killing things, all right? And to be sterilized, the FDA says you need to have essentially a 6 log for something to be considered sterilized. So what I'm doing here is now I'm going to introduce an antibiofilm gel, all right? And we're basically going to talk about how the broad spectrum of it works. We're going to be talking a little bit about its efficaciousness across different bacteria. This is just a new armamentarium. The name of this product is called SURGX. And essentially what we have found is, in evaluating, when they did suspension time kill testing on planktonic activity within the gel for a 2-minute exposure, they found that using SURGX, you find a 7 log of staph within 2 minutes of using it. Like I said, FDA basically says there's a 6 log kill to be considered, for something to be considered sterilized. The most common isolates, what you're seeing here, and this was across the board, what was tested was SURGX. Across the board, these 3 are the 3 most common that are actually found in surgical site infections with C-sections. So Staph aureus, Klebsiella pneumonia, and E. coli. And you can see just a broad spectrum of activity with excellent log. And this is within just 2 minutes of exposure to the antimicrobial gel. Now, this graph basically is showing the bacterial growth of SURGX, and they compared it directly to what do we most commonly use. Everybody uses different things, but the silver dressing, when that came out, that's the one you want to use on the obese patient. That's the one you want to use if you're ever worried about infection. It's silver dressing, right? So Aquacel, silver barrier dressing, basically SURGX or the Antibiofilm gel. We compared that to the Aquacel, and they basically did the incremental laboratory testing, and they did that. It basically shows that you get a 5-day efficacy in preventing bacterial growth when you use SURGX. And kind of one of the things that I find pretty interesting is we're told when we put on the silver dressing on the patients, they are supposed to take it off in 7 days. So we're assuming that there's 7 days worth of efficaciousness through it. Well, what they found was in comparison of both of these, essentially over the course of 5 days with using the Aquacel, there was a log reduction in the growth, but it was still present. And then you started seeing it come back up around 5 days. Whereas you consistently found through the Antibiofilm gel or through SURGX that it never grew. And so SURGX seemed to be playing a much bigger role in treatment of infection and treatment of managing the growth of that bacteria and managing essentially the biofilm. Out of Texas Tech, this was a great study using basically the mirroring model. And what they did was they did punch biopsies, and they were bacterial infused punch biopsies into the rat model or the mirroring model of the rats. And what they found was using MRSA and Pseudomonas, which all of us, these are two of the ones we hate the most. What they found was 24 hours after treatment. So this is the punch biopsy that was put in there with the bacteria. And 24 hours after treatment, this is what it looked like. 48 hours after treatment, you start seeing that reduction. All right, that's occurring. And then 72 hours after treatment, you're noticing an even more significant reduction. Actually, 72 hours of treatment, you don't see anything that's happening here compared to the control. So again, this is a gel that you put on the skin. You put it right post-operatively, and we're showing a great reduction in the biofilm-associated growth that's occurring. So what is SURGX? I mean, it's a new weapon that we're going to use in the Armamentarium. It's basically an antimicrobial gel. It deconstructs that biofilm matrix. It destroys the bacteria within the gel, and it defends from recolonization. It's a non-toxic product. So basically acts on the EPS. The non-toxic product, this has a couple things in it, all right? BZK or benzalkonium chloride, which is essentially a surfactant in soap, right? It has citric acid in it, which is in orange juice. It has a PEG gel. The PEG gel basically allows for oxygen transport, and it won't macerate the wound. But the two big components in this is citric acid and benzalkonium chloride. Yeah, everybody, we give our postpartum patients orange juice. They take a shower and put soap on them. BZK is a surfactant that's found in soap. Citric acid, we find it in orange juice. This is non-toxic. You basically, yes, we don't recommend putting SURGX directly on the breast so that the baby doesn't ingest it along with the formulation of the milk, but it is a non-toxic product. As long as the baby's not ingesting it, we're good. It's safe. It's safe. Safe with breastfeeding across the board. All right, so SURGX can be used with multiple dressings. All right, we use different closure techniques. So some people use staples, some people use suture, others use Dermabond, Histocryl, others use the Vicryl staples. Forgive me, I'm blanking on the name, but across the board, SURGX can be used with all this. It can be used with the collagen dressing. It's a non-toxic product, and it is compatible with the majority of other dressings that we can use. The one thing you want to try to minimize or avoid is the alginates, and that's like the Maxorb, mainly because it's not that it poses a risk or it's a problem to the patient. It just deactivates the silver, so it's almost just no point in doing the alginate dressing if you're using SURGX there. But otherwise, yes, absolutely. And you know, I gave a webinar regarding SURGX, and somebody asked, you know, can you put it with Dermabond? Absolutely, you can put it with Dermabond. Actually, if you think about it, when you see Dermabond, people come into the Dermabond about 2-3 weeks post-op, you see it's all cracked and mangled and kind of discolored. Well, that cracking area, that's perfect breeding ground for bacteria. So if you have the SURGX there, you're decreasing across the board that biofilm matrix. You're decreasing the capability of it to go and to grow and to develop that bacteria there. So you can absolutely use it with any one of these, with the exception of the alginates. And like I said, with the alginates, doesn't pose a threat, it just deactivates the silver. So in conclusion, basically C-sections are one of the most common operative procedures. Surgical site infections are a worldwide problem, and we know this, and there's significant physical, emotional, and financial impact to those patients and the healthcare system. I said we can get up to about $1 billion based on that Barnes and Jewish study of 5%. You can get up to anywhere from millions to billions of dollars in spending just for surgical site infections. This is something that's huge on the JCAHO agenda this year, and it's something as hospitals, you're seeing all the surgical site infection bundles come out, and they're talking about the different things from preoperative to postoperatively. The concept of biofilm, it's something we got to bring back into the picture and just think about it, because it really is. And biofilm is that community of pathogens, and you got this complex structure, entangled polymers that are strengthened within those metallic bonds. Remember, I use that concrete analogy, or it's you basically got this community like a castle. If you think about, like, what did people had to do to get into that castle? You had the rocks that were coming through the catapults. They would try to ram through the doors. I mean, you have to break through that to get to the community inside. That's exactly kind of what that biofilm is. It's that castle. It's those castle walls. It's protecting it. And that formation happens in as little as 5 minutes. So within milliseconds, it starts the process. It can use the host's structures. And then the traditional antibiotics and the antimicrobials, they're going to act specifically on the bacteria cells. But if they're not getting to those cells, they're not doing anything. They're not going to be able to have their maximum efficaciousness, if you will. Whereas if you do the proactive management from the biofilm, you minimize that safe haven, that you minimize that castle, that community from working, where they're able to thrive. And then you utilize, basically, it's a non-toxic agent. So SURGX is non-toxic. It's a safe antimicrobial gel. You can put it on at the end of the surgery. It's a highly effective tool in the reduction of the surgical site infection. And y'all, it costs $72. It's such a minor cost in relation to what the potential cost of surgical site infections are. Just to let you, like, a little example I have, and though it wasn't on a C-section, it was a patient that I had she ended up having a ruptured ovarian cyst, had basically hemoperitoneum, took her to the OR, had to drain it. She ended up, through the umbilical site incision from the laparoscope, she ended up developing a nasty wound infection, a surgical site infection. She ended up having about an 8-centimeter abscess that I ended up having to open up and take her back to the OR and open up. She went 6 months through combination of wound vac therapy, dressing changes. It took her 6 months to be fully healed up. That's not an easy feat. That's not an easy thing to deal with. And it's just the mental mindset that she went through with all of that. So here we got a simple product that essentially just jumps in and minimizes and prevents the ability of that bacteria to thrive. And so $72. I think it's something that is benefit, and it opens the door to a different way of attacking essentially the surgical site infections. And here's a couple of questions that get asked frequently. One big thing to realize about this hospital data and the surgical site infection data, a lot of that, and I see this even within Northside Hospital, is that we struggle with acquiring data from a hospital perspective because you can only rely on what you have in the hospital unless you have a great integrated network with the community physicians. But the majority of surgical site infections are not handled in the hospital. They're actually done on an outpatient basis. And so it's the rare few that go to the ER, or the rare few that end up, having something develop and are hospitalized at that point in time. Now, generally, surgical site infections, we would see, how often do we see them, and what's that time frame? Usually we would see it within about a 7 to 14 day time frame as to when we see them. And it's usually dependent, the ones that are more delayed, that's usually masked because they had an underlying hematoma or seroma or something that was what was keeping it from manifesting as a cellulitis or manifesting. So it got hidden and it took a little bit more time to come out. That's one big question that I've been asked, is like the time frame that we usually see this surgical site infection. It's about 7 to 14 days. And then we do see it. So even though the numbers, I struggle with some of the numbers of surgical site infection because I do believe that there is a higher number than what the hospital can report. But that's just because of the lack of the ability to get to the data. A second thing that I get asked is closure technique. Does closure technique make a difference? And, everybody's got their different ways of closure technique. SURGX is going to, whatever closure you desire using, you can do SURGX. The only thing you can't do with SURGX is put it on an open wound. So you have to put it at the end of the case and where it is like closed up. And then put it around there. So with SURGX, as long as the wound is closed, no matter how you've closed it, there is not, and it doesn't make a difference one way or another if you use staples, if you use sutures, that closure technique won't make a difference when you're using SURGX to put on top of the wound. So this concludes the impact of biofilm on C-section presentation. SURGX and the antimicrobial gels definitely play a huge role in preventing surgical site infections. I hope that I was able to educate everybody on that biofilm matrix and understanding a little bit more about why we deal with and our struggles with infections and surgical site infections. And I look forward to using this as a new tool in our armamentarium. My name is Christopher Basile. Thank you very much.